My opportunity to start off the afternoon session. And this really, I think, brings full circle to what we've been addressing over the last week. I think it's been an outstanding week. We've had excellent speakers. If you recall, we started with a bit of an overview about One Health. Dr. Cheryl Stroud, who is the executive director of the One Health Commission, presented, I think, an outstanding overall presentation to really begin laying the groundwork. And as we know that One Health deals with the intersection between the human, the animal, and the environment, and all the things associated with that, when we think about what we do, certainly at the University of Maryland, within our college and many of the other colleges, there aren't many things that we do that doesn't really fall under the One Health concept and the One Health initiative. And so I think that we had a even greater understanding about how the work that we do, both in the laboratories, in the field, interacting with so many different people around the state and beyond, really fits under the One Health perspective. The topics that we covered this week dealt with mental health, animal production and diseases, vector-borne diseases, chronic diseases, climate change, food and waterborne diseases, and water quality. And so it is, again, a very, very large scale menu of topics that fit within this overall perspective. We've asked Dr. Boris Lushniak to present today and to really, I think, come to closure in terms of, or maybe not come to closure, but actually stimulate our thinking even beyond where we currently are right now with regards to One Health and maybe where we all fit within that realm as well. Let me give you a little bit of background on Boris. He leads the School of Public Health. In fact, he has been a huge guide and resource here at the University of Maryland, guiding us through this current pandemic that we find ourselves in addition to leading his college. As Dean, Boris has developed several new academic programs, including the accelerated and dual degrees. He's helped launch a global health initiative and provided leadership in the context of the global coronavirus pandemic. Dean Lushniak has had a distinguished career in federal service, culminating in leadership roles as U.S. Deputy Surgeon General from 2010 to 2015, Acting Surgeon General from 2013 to 2014, and in 2015 he retired as a Rear Admiral for the U.S. Public Health Service Commission Corps, where he was an officer for 27 years. He was part of the CDC team that responded to the devastation at Ground Zero after 9/11. He served as the FDA Deputy Incident Commander for the 2009 H1N1 pandemic response, and he led the U.S. Public Health Service Hospital providing care to Ebola patients in Liberia in 2015. Dr. Lushniak is looking forward to launching a new undergraduate degree in global health at the University of Maryland in partnership with a variety of colleges, including our own college in agriculture and natural resources. Boris and I had the pleasure to travel to Israel together to address issues surrounding water quality and quantity and work with an institution there, Hebrew University. And our colleges also work very closely together on a variety of issues surrounding public health. I'm sure you're going to find his presentation about global priorities and infectious disease disasters stimulating and thought-provoking. Boris, thank you so much for being here today and sharing your thoughts with us.
Great. Thank you so much, Dean Beyrouti, and thank you for having me. And, it is great that we do have these partnerships, along common themes. And Craig and I are not only co-deans, but we're good friends. And that makes life a whole lot easier. And when he came to me asking me to discuss the One Health concept from a public health perspective, I was really enthusiastic. And as Dean Beyrouti mentioned, when I was in the office of the U.S. Surgeon General for 5 years as the deputy and the acting for a short bit, year and a half, almost 2 years of it as an acting position, one of the things I did was lead the Commission Corps of the U.S. Public Health Service. And that's what really taught me about the One Health aspect from a public health aspect, because within that uniform service are 12 different professional categories. And they include the usual, right? The scientist category, the pharmacist category, physicians, nurses, but it also included a separate category of environmental health officers. It included a separate category of professionals such as veterinarians and therapists, right? And in that realm, within these categories, what I realized was that this One Health concept of us working together to achieve a common goal is critical. So for the next 45 minutes or so, I'm going to sort of go through my perspective from a public health and a medical aspect of the importance of One Health, bringing up some of the global priorities out there and sort of culminating in the examples we've seen in terms of the infectious disease disasters that have existed throughout the history of mankind. I am going to go to share screen at this point, and there will be a few slides that I'll be sharing with you. Let's begin. Okay, do we see the slides? I need a heads up from
Looks
somebody.
great. Looks
Okay,
fantastic.
perfect. Thank you. Okay, so this is me, and disclosure, conflicts of interest. I don't have any relevant conflicts of interest. We're talking about health here today. And actually, let me go back because I should probably make this more official here. Is that when I talk about relevant financial relationship with any commercial interest, don't have any. No off-label discussion of drugs or devices. We'll talk a little bit under the current coronavirus situation of emergency use authorization and some of the drugs that are being used out there and approaches for treatments. My work is supported by the state of Maryland, as you know, as we all are at faculty and staff at the University of Maryland College Park, although formally I've had a whole conclave of 28 years of government service with multiple agencies. The letters are described here. We're going to be talking about health. And before we talk about One Health, let me just remind you, I'm a strong believer in this, of the World Health Organization definition of health. First of all, it's aspirational. It talks about it being a state of complete, which means we're there. We're not halfway there, we're there. But a state of complete what? Physical, mental, and social well-being, and not merely the absence of disease or infirmity. And, you know, this is an important statement that I have it on my office wall, had it on my office wall in the Surgeon General's office, and I have it at the Dean's office. And it reminds me, right, whether you're looking at it from a One Health perspective, right, whether you're looking at it from a public health perspective, whether it's from a societal perspective, is that this is what drives us, right? This is what we're trying to accomplish for the good of humankind. Now, when we talk about health, and this is a little bit of a busy slide, but this really begins the intro to the One Health from my perspective, right? Is that when we talk about the determinants of health and disease as humans, right? Where we are, how we live, where we learn, where we work, where we play a role. These are the determinants of health. And it's affected by our social environment, our physical environment, and yes, our genetic environment, right? And ultimately, the goal is well-being and prosperity. And built into that are our individual responses, how we, you know, are we healthy? Are we functioning? Diseases that we may come in contact with, the issue of healthcare, all that interplay. But the key component here is, notice it's a social environment, physical environment, genetic environment, ties in well with the World Health Organization definition of health. I'll also introduce the concept of public health here. And I like to go back almost 100 years, right? Or 100 years this year. C.A. Winslow, who is a microbiologist, one of the founders of the American Public Health Association, a big leader in public health in the early part of the 20th century, described it as, I keep telling my students, it's the 3 Ps. It's a science and art. It's about preventing disease, prolonging life, and promoting health. But ultimately, it also describes to us that it takes a village to do this, right? This isn't just in the hands of public health people. It's not in the hands of medical people. When we talk about public health, it's organized efforts and informed choices of society, organizations, both public and private, communities, and individuals. So it takes a village is really a component of public health. Now, you've heard this earlier during the whole aspect of this conference. Let me angle me a little bit because I'm still getting used to, I got a brand new accoutrement from my desk. So I realized my head was cutting off. So I'm back full-fledged now. But I realized early on in our discussions this week, we talked about One Health. And here I'm referencing from the CDC perspective, and this is probably going to be just a refresh, right? First of all, what's the concept of One Health? It's collaborative, multi-sectorial, transdisciplinary. key components to this. It's work at all levels, local, regional, national, global levels. Its ultimately goal is achieving optimal health outcomes. And again, I reference here the World Health Organization definition of health, and it recognizes, as Dean Beiruti had talked about, this interconnection between people, between animals, between plants, and with the shared environment that all those components play a role with. In terms of changing factors of One Health, again, you've discussed it as part of this meeting this week. Many of you have participated throughout the week, and we talk about the idea of what's been changing. Well, human populations growing and expanding into new areas. There's closer contact with wild animals and domestic animals, livestock and pets. There's changes in climate and land use and disruptions in the environmental conditions and habitats, right? People are moving all the time. Animals are moving. Animal products are moving. This is a key component of One Health. Our world is in transition, and this results in more of these opportunities for diseases to spread between animals and people across borders and around the globe. Many issues come to mind, many of which you've discussed already: the zoonotic diseases, antimicrobial resistance, food safety, food security, vector-borne diseases, environmental contamination. But we also include other aspects which are kind of, at this point, sometimes considered fringe of One Health, but the role of chronic and non-communicable diseases, right? And how they interplay with the whole world of One Health, mental health issues, injuries, occupational health. So in essence is the One Health concept, if we really look at it aggressively, does encompass many of the issues that we see in public health. And in terms of the partnerships, this is just a short listing. If you don't see your own profession here, it's you have a place here in the One Health. Whether it's the whole idea of human health, whatever interplay you have in animal health and in environmental health. Almost all of us in this realm fit into this One Health approach. And it's this triangulation, again, this interdisciplinary approach that we see. Last year, and I wanted to preface last year because this year's big threats to global health are a little bit different. And so I profiled last year's, the 2019 World Health Organization 10 Big Threats to Global Health. And the reason I didn't want to throw in this year's is because to a large extent we've been, hurt by COVID, which I'll discuss at the end of this talk. But the big threats to global health from the World Health Organization are air pollution, climate change, non-communicable diseases, fragile and vulnerable settings, antimicrobial resistance, weak primary health care, vaccine hesitancy, dengue, HIV, influenza pandemic, and Ebola and other high-threat pathogens. And again, this is pre-COVID. And the ones I delineated in red are the ones I'll expand upon a little short with a slide each to discuss this whole perspective, right, of how the interplay of World Health Organization, 10 big threats, interplay directly with the idea of One Health. So let's talk air pollution, climate change. You've had some discussions about this earlier. 9 of 10 people breathe polluted air every day. It kills 7 million people each year due to cancer, stroke, heart, and lung disease. 90% of the deaths are in low and middle income countries. Burning fossil fuels are a major contributor to climate change. So we have the sort of a potential pathway to delineate ahead of us of how do we begin solving this problem. Expected to cause 250,000 additional deaths per year from 2030 to 2050 due to malnutrition, malaria, diarrhea, and heat stress. So here you bring in sort of the changes of our environment, and we're on course by more than 3 degrees centigrade this century to warm our planet. So the reality is that things are changing, and the reality is that also that One Health plays a key role in terms of dealing with that. Non-communicable diseases, right? We always look at this idea of, even in the realm of COVID, numbers are going to be very different. The statistics will be different for this year, but in general, non-communicable diseases, the chronic diseases, account for the overwhelming number of deaths worldwide, right? 70% of all deaths, 41 million people die from diabetes, cancer, heart disease. 15 million people die prematurely between the ages of 30 and 69. Again, low and middle income countries inordinately affected by this, 85% of deaths in those countries. The risks are out there: tobacco use, physical inactivity, harmful use of alcohol, unhealthy diets, and air pollution playing a role in all this. And then you throw in the issues of mental health issues, right? Suicide as the leading cause of death of 15 to 19-year-olds. The fragile and vulnerable settings as another global health priority from World Health Organization. 22% of the global population, 1.6 billion people, that's with a B, billion people, live in places where protracted crises leave them without access to basic care. This includes individuals affected by, again, climate change and war playing a key component. Drought, famine, climate change, conflict, right? Population displacement. And this ultimately affects people's access to health systems and the ability to get health services delivered to them. Big component of One Health, right, is antimicrobial resistance. We see this now with treatments of pneumonias, TB, gonorrhea, salmonellosis, right? Let's just talk about TB. 10 million cases each year, 1.6 million people die each year. We forget. We don't see it that often in the United States, right? It's not out there in huge numbers, although it has been growing. But worldwide, 10 million cases each year. Nearly over 1.5 million people dying. In 2017, we had 600,000 cases that were resistant to rifampin, right? A common therapeutic. 82% had multi-drug resistance. To a large extent, we see a lot of the bacteria also now developing a resistance, right? And this is driven partially by overuse of antimicrobials. Yes, I as a physician am part of the cause, because the easiest thing to do is to write a script, say, take this antibiotic, even though you may not need it, right? As well as use in animals. Increase awareness, knowledge, reduce infection, encourage prudent use. That's part of the solution to this. Let's talk briefly about vaccine hesitancy, yet another one of those World Health Organization perspectives of importance for 2019. Vaccination is the #1 most cost-effective way of preventing disease, right? We prevent 2 to 3 million deaths per year. A further 1.5 million deaths could be prevented if global coverage could improve. So we're not doing as well as we should be. The issue of complacency, inconvenience, lack of confidence. We can achieve many things. We can eliminate cervical cancer through HPV vaccine. We can eliminate polio, right? Polio is a prime example. We've already successfully eliminated smallpox off the face of this earth, right? 1979 was the last case of smallpox on this planet. By 1980, World Health Organization denoted it as being extinct on this planet. The next one in line is polio. 1988, we had 350,000 cases, less than 30 cases in 2019 in Afghanistan and Pakistan. So we are making achievements on this realm. Throw into this whole idea of even the idea of, from the veterinary perspective, of vaccination in animals as a pathway to potential decrease of disease in humans as well, part of the One Health approach. You had talks earlier this week about vector-borne diseases. I'll remind you about dengue, right? One of the World Health Organization priorities. Mosquito-borne disease, flu-like symptoms can kill up to 20% of those with severe dengue. Occur in the rainy season, Bangladesh, India. The rainy season has been lengthening, and spread has been seen to temperate areas such as Nepal. Climate change. 40% of the world is at risk for dengue, 390 million infections per year. Again, a control strategy that needs to be built into it. And the last two, I'm sort of going to bring together, because we talk about in 2019 our fear of a global influenza pandemic. Well, we certainly have a pandemic. Guess what? It's not influenza. And then we talk about emerging diseases, Ebola being a prime example, but others included in that. And therein lies the crystal ball of, COVID coming aboard, interplays with both these. When we talked about the global influenza pandemic, the feeling was it will happen. When and how severe, right? And this is circa 2019. The global defenses are only as effective as the weakest link in any country's health emergency preparedness and response system. What's interesting is at the latter part of 2019, there was a scoring system set up in terms of countries being prepared for global health crises. Guess who was the #1 country ranked in that? No one scored 100 points out of 100 points, but like 89 points, I think, was the US. We were the most prepared for anything. And look how that predicted response. Interesting, isn't it? Need for global surveillance and response, diagnostic, vaccine, antivirals. Again, I emphasize, this is circa 2019. no one knowing that COVID-19 was going to hit us. But we also were worried in 2019 of Ebola and other high threat pathogens, right? I'll talk briefly of the Ebola epidemic in West Africa, of which I was part of a response component of the US government, right? But also, we still have an issue in the Democratic Republic of Congo in 2018. Two separate outbreaks in 2018 spread to cities and in conflict zones. The issues of responses in massive urban centers, we saw this a little bit with Ebola. Notice the list back in 2019 of these other high threat pathogens. We talked about Ebola, hemorrhagic fever, Zika, Nipah, MERS, Middle East Respiratory Syndrome, coronavirus, right? Severe acute respiratory syndrome, SARS was on the list. Nobody predicted COVID-19, but we did, in fact, even in 2019, say the unknown. What is disease X? And now by November of 2020, we know what disease X is. So that's the World Health Organization perspective on global health priorities and how it ties into One Health. I want to talk a little bit about the concept of infectious disease, and I'm going to introduce the concept of infectious disease disasters and use 3 examples, right? First of all, I do want to remind you, we've done incredible things in the realm of public health over the years. And this is, again, one of those other things that are always posted in my offices, right? This is a reminder when I kind of get down on where we're at, right? With accomplishments. This is from a 2019 or a 1999 perspective, the major accomplishments seen for public health in the 20th century. And notice the listing there. I won't read through all of it, but these are what the CDC looked back at 100 years of progress from 1900 to 1999. And notice, obviously a biggie from the Surgeon General's office perspective was the last one, was recognition of tobacco as a health hazard. Notice it only says recognition. If we start designing this same slide, and it'll say at some point, many of us won't be alive to see it come out, I'm sorry to say, but it'll say from the year 2000 to 2099, what were the achievements? Can we change that word recognition of tobacco as a health hazard to potentially elimination of it, right? Look at the other ones that are on here. But notice that one of the public health achievements included control of infectious diseases. And I'll remind you, in the year 1900, we barely understood the concept of virology, bacteriology. We certainly didn't have antimicrobials, right? We didn't know much about diagnosis or treatment of these diseases. Worldwide, people died of infectious diseases, as they do today. But we also didn't have the concept of vaccinations, right? So the reality was that in 1900, right, the world was a different place. By 1990, it had changed. And we talked about the idea of control of infectious diseases. Now, I was in medical school back in the late 70s, early 80s. And I still remember one of my microbiology professors sort of touting this line, right? It's an infamous quote in the history of biomedicine that around that era was talking about what? It's time to close the book on infectious diseases and declare the war against pestilence won. It was incorrectly attributed to a US Surgeon General, right? Urban legend that he had said this. The primary source for the quote has never been identified. But we were sort of filled with that sense of hubris in the medical profession, right? This is 1979. I was a freshman in the first year med student, and someone said, it's almost over. We'll concentrate on the chronic diseases, but we have all the tools. We have vaccines, we have antivirals, we have antibacterials, we have antifungals. We will eliminate infectious diseases. And what happened around that same time? HIV/AIDS comes along, right? A brand new disease that no one has ever seen before. And that took that sense of hubris, of overt pride, and turned us, I think, into more humble individuals. But that was only the first time we've seen it, because since then, and throughout the course of the 20th century and into the 21st century, we've been hit with, in essence, infectious disease disasters. And how do I define this? These are events that involve the bioagent, right, that result in mass casualties. It could be a bioterrorism attack, anthrax as an example, pandemic, outbreak of emerging or re-emerging diseases. And we really bring in the concepts of emergency management here. This is specialized mitigation, preparedness, response, recovery. to some extent an overlap with examples of the natural disasters and response, but certainly it has its own idiosyncrasies. Another one of these scary slides out there. And notice this is a dated slide, but this shows the world map, and with newly emerging diseases, re-emerging, resurging diseases, and deliberately emerging diseases. The concept of this map is what? Is infectious diseases are all over and we're being hit from various angles. Let's talk a little bit about one of those priorities, and specifically just about pandemic influenza. We'll finish up this talk with talking about COVID, but about pandemic influenza. When I was at the Department of Health and Human Services, we had a playbook that had come out, and the quote from the playbook was what? It is clear that pandemic influenza has the potential to pose disease control challenges unmatched by any other natural or intentional infectious disease event. Again, this talked about influenza, but using that same quote, we can see that we're living it right now, COVID-19. And, we kind of look back at the history of Spanish flu, incorrectly named the Spanish flu, the flu of 1918, 1919. And in essence, how far we've come with so many different things. But our preparedness was what? Was setting up people in field hospitals, trying to separate them accordingly. But, the reality was incredible medical progress, but still, sometimes we go back to basics. So let's talk about the idea that every year we have a outbreak of influenza. It happens every year. Some years are worse. This isn't a pandemic. It's seasonal influenza. Some years are worse. Some years are harsher. Some years are deadly, and other years are mild. Just to remind you, orthomyxovirus, negative stranded RNA virus, as is COVID, right? Or SARS-CoV-2, an RNA virus. One Health, wild birds are the natural host for all known subtypes of A. There's low pathogenic avian flus. They're highly pathogenic avian flus, right? These can infect people. They can affect birds, pigs, horses, other animals, right? So the reality is that already in seasonal influenza, a seasonal variety of influenza that comes along and hits us every year. That's why we plead with people. If you're and this is my public service announcement, if you haven't gotten the flu shot this year, get it for goodness sakes. But then we have seasonal influenza, and then we have pandemic influenza. And I'll remind you, geographic designation is the pandemic, an epidemic, an increased outbreak of disease that, however, in this case is occurring not within a nation, not within certain confines, not within a region of the world. It's an epidemic occurring worldwide, crossing international boundaries and usually affecting a large number of people. For any pandemic, whether it's influenza or whether we see it with COVID, 3 conditions need to be met. It's a brand new pathogen. We've never seen it before. Usually, always, in recent times, coming from the animal world. New pathogen, therefore no immunity. It needs to produce serious illness in humans, right? There is a sense that, mild diseases aren't really oftentimes listed as pandemic. We might not even notice that we're having them. Morbidity, mortality play a role. And the third key component for a pandemic is it's able to spread efficiently from person to person. So those 3 conditions obviously have been met with COVID-19 and have been met with influenza pandemics of the past. And let's briefly remind us that pandemics are not a novel concept, right? There's a whole history of pandemics and epidemics affecting the globe, right? Whole listings of diseases, right? The plague, oh my God, it's the plague, the Black Death, right? Incredible devastation of human populations. But here are basically the previous pandemics of the 20th century and going into the 21st century. All influenza. We've never had a pandemic that wasn't influenza. And you can see the worst one, 1918, 1919, 40 to 50 million people died worldwide. In the United States, 675,000 deaths, mostly young adults. It was deemed incorrectly, as I mentioned, the Spanish flu, H1N1, and infected 20 to 40% of the world. But sometimes we need to be reminded, we had other pandemics in the 20th century, 57, 58, 68, 69. You can see the parameters listed, none as bad as the 1918, 1919 influenza. And then sometimes we have to be reminded that in our lifetimes, we actually had another pandemic, and that was 10 years ago, right? Now 11 years ago, 2009, the H1N1 influenza pandemic. Not a major killer, 12,500 people. dead in the United States from that. We had 60 million cases in the United States, 274,000 people hospitalized. So it had its effect. World deaths, perhaps 500 plus thousand individuals. So to a large extent, right, we have had pandemics occurring like this. Now, let's go back 100 years. And I love this quote from the Journal of the American Medical Association. So realize we're on the cusp of what? Of World War I being completed. And I'll read this quote because it's unlike other things that we write in scientific literature now. The 1918 has gone, a year momentous as the termination of the most cruel war in the annals of the human race, a year which marked the end at last for a time of man's destruction of man. Unfortunately, a year in which we developed a most fatal infectious disease causing the death of hundreds of thousands. Medical science for 4.5 years devoted itself to putting men on the firing line and keeping them there. Now it must turn with its whole might to combating the greatest enemy of all, infectious disease. Interesting reflection from 100 years ago. And what do we know? I mean, again, I'm a former officer in the U.S. Public Health Service Commission Corps. Right, here's someone who is part of that legacy, Officer Joe Cobb at the Chicago Marine Hospital. This photograph, our beds were filled as fast as they were empty. It makes us reflect on what's going on within some hospital settings on this very day in 2020. Notice the curves from 1918, 1919, New York, London, Paris, Berlin. Unlike what we're seeing today, right? A surge, a wave, a loosening up, second surges coming along. 100 years ago, the headlines, new flu cases reported, flu hits fire departments, schools closed. You know, the more things change, the more they seem the same. And when it came to infection control, right, the saying from 100 years ago, obey the laws and wear the gauze, protect your jaws from septic paws, right? That's me and my family on the right-hand side of this slide, right? Wearing my TERP colors. But the reality is that despite all the advances, we're still kind of back to basics, aren't we? And what's changed with our fear of pandemics? Well, it's quite clear. This is a One Health model. Global population, larger, more urbanized. Levels of international travel is greater. Billion passengers annually in the US in 2018. Increased population of elderly and those with chronic conditions. Right? These are the trends affecting any pandemic impact. I'm going to remind you of what took place 10 years ago, right? 10 years ago, we were actually, and I was then running the Office of Counterterrorism and Emerging Threats. The key feature here is the emerging threats component of that office at the Food and Drug Administration. And we were preparing for the next pandemic, influenza. And we were convinced, number one, it's going to start in China. So we have our binoculars primed there. And number two, it's more than likely going to be H5N1, right? The bird flu. All of a sudden, we get sucker punched. It's not in China. It actually, the first case is in California, Southern California. A new flu virus, right? Distinct from previous H1N1s. What caused it? This is, again, the One Health approach, a quadruple reassortment of this virus. 2 genes from swine flu in Europe and Asia, 1 gene segment from human influenza, and gene segments from North American avian and swine flu. First cases probably were occurring in March and April of 2009 on the Mexican-US border. The first case was confirmed in a 10-year-old boy by lab testing on April 15, 2009. Second case was confirmed 2 days later in an 8-year-old 130 miles away. I remember this because by the time we had the second case, we were now panic-stricken. Honest to God, goodness, right? We knew something was happening. Luckily, it didn't hit as hard as we thought we were. We thought this was going to be a big one. Quickly determined there was person-to-person spread, secondary attack rate, 8 to 12%, and ultimately by June 11th, it was designated a pandemic in 70 different nations. What do we know about that pandemic? 2 waves, a peak in June and October. Hospitalization rates were highest in children. Estimated 60 million cases in the US, as I mentioned, 12,500 deaths. Higher burden of disease in young people could have been due in part to previous exposure of older persons to antigenically similar viruses. Pandemic lasted from June of 29 to August of 2010. What helped us then? 4 major pillars: surveillance of disease. community mitigation, vaccine delivery, communication. Let's remind ourselves what worked 10 years ago. And the main messages 10 years ago was what? Cover your nose and mouth with a tissue when you cough or sneeze. Wash your hands. Avoid touching eyes, nose, mouth. Stay home if sick and avoid close contact, less than 6 feet with persons with influenza-like illness. The only thing we didn't push 10 years ago was masks, and that's been a major public health change and major public health challenge. So let's move from that to the other World Health Organization prayer. We talked about Ebola, and let's remind ourselves, 2014 to 2016, Ebola outbreak, the largest in history, and the first outbreak ever seen of Ebola in West Africa. Ebola as a virus was discovered in 1976. So this is a relatively new virus. It affected in Western Africa multiple countries, the three big ones, Sierra Leone, Liberia, and Guinea. The strategy, I was an officer in the US Public Health Service and a responder, was to diminish the threat of Ebola in the United States and the world by defeating it at its source. And I, as the acting Surgeon General, was at hearings in front of Congress. And there were elements they said saying, bring everybody home. Let's shut our borders. Let's clamp this down. Well, it was a different disease than COVID-19. And the reality was going there and defeating it at its source was the right approach. So US significantly ramped up its effort to fight the virus in that West Africa. And the history was this never was a pandemic. It was declared an outbreak, a public health emergency of international concern only in August of 2014, after the disease had in essence been percolating in Western Africa since about January of 2014, perhaps even December of 2013. This was my home for about 3-4 months, right? This was something called the Monrovia Medical Unit, the only US government hospital set up to treat Ebola patients in West Africa. And the mission was very distinct, right? The uniforms of the Public Health Service, the flags are flying. It was fighting a disease, which was in essence a zoonotic, right? Spread to a population and trying to fight this disease with taking care of individuals with the disease, but also the bigger public health approach, which is getting into the communities and coming up with those mitigation factors, with those preventive factors that needed to be done. Ultimately, the goal was to try to treat people and heal them. With inadequate treatments, it was supportive care for the most part. This was our survivor wall. And we treated people there who were very distinct in the US government hospital, the Monrovia Medical Unit. They were healthcare workers widely defined. So the first responders, mostly Liberians, who had been out there taking care of Ebola patients, got the disease, were treated in the US government hospital. Yes, we had our deaths, but we also had our cures. And the motto of the cure was, today I'm healed, tomorrow I return to heal another. What do we know about that outbreak? Ultimately, we had a lot of news about this, but, I dare say you look at the numbers and, it was devastating. 28,000 infected persons, 11,000 deaths, death rate roughly about 40%. What was the impact on countries outside of West Africa? 36 cases, 15 deaths in other countries. We had 9 cases in the US, all imported with 2 deaths, and then 2 additional cases in nurses in the United States. Source, likely zoonotic. We still have many unknowns. Bats, non-human primates as potential sources of this. And now I'll complete the discussion, right? Which this is the latest infectious disease disaster, and that's COVID-19. So remind ourselves, large family of RNA viruses. Once again, the One Health approach on this. Infect many species from rats and bats to beluga whales. Mutate slowly compared with the influenza virus, which is another RNA virus. And we now have 7 coronaviruses that we know infect humans. There's 4 common cold viruses as listed here, probably been infecting humans for hundreds to thousands of years. Who knows? At one time, these common cold virus might have been akin to COVID-19. We don't have that documentation or that data. 3 new emerging viruses. And this is sort of the big One Health concept yet again. In this century alone, this is SARS-CoV-2, right, which is the virus causing the disease COVID-19, is our 3rd coronavirus outbreak. It's the only one that's become a pandemic, but let's remind ourselves of the 2 previous outbreaks. Severe acute respiratory syndrome, SARS, first reported in Asia in 2003. An animal virus, perhaps from bats, the civet cats. Ultimate toll, little over 8,000 people were infected, only 8 in the United States, in 24 nations, with 774 deaths, death rate of 9.5%. What happened to this disease? Really strange. It just disappeared. Right? 2003 to 2004, and it's gone. MERS, Middle East Respiratory Syndrome, first reported in Saudi Arabia in 2012. Another animal virus, perhaps from camels, dromedaries. Impact, 2,500 people, 2 in the US and 27 nations. A much deadlier virus, 34.4% death rate. And this one didn't disappear, but we only have small numbers, single digits. I think 6 cases of MERS diagnosed last year. It never became a pandemic. And now we have COVID. And I don't want you to sort of concentrate. I'm going to pick out the highlights of this. So let's all remember what we were doing in preparing for New Year's, right? What were you doing on New Year's Eve 2019? You can probably remember. You're probably going to have dinner, go out, have a party, have friends over, perhaps go to sleep early. Right? That's the day where the World Health Organization office in China was informed of people with pneumonia with an unknown cause. By the 3rd, it's 44 suspected cases, 44. And maybe it made the news at that time. On New Year's Eve, none of us paid attention to this. By January 7th, a novel coronavirus was identified. Now, that's the beauty of science, isn't it? Right? In 1918, during the H1N1 influenza, during the Great Pandemic, we didn't even know whether this was a virus or a bacteria or some other cause, right? 100 years later, in a few days, we figured out it's a brand new virus. Then we have a death. We know it's serious. The genetic sequence, oh my God, science of the virus is shared by the 12. WHO confirms human-to-human transmission. That's another key component now of this being a pandemic. We have our first US case. Wuhan shuts down. WHO declares a public health emergency of international concern. We declare, the US, a public health emergency. We ban entry from China. We now have a CDC diagnostic emergency test that's out there under emergency use authorization by the FDA. We know its problems. We have a death in the US by February 6th. By February 10th, we have over 900 deaths worldwide. Why is this important? We're heading in a bad direction. This surpasses both SARS and MERS in terms of mortality. By February 11th, we have a brand new name, COVID-19. Beauty of science, biotech firm Moderna sends a candidate vaccine to NIH. We're moving ahead. CDC key official says to the world, this might be bad. And in essence, she gets castigated, right? She gets condemned, saying, why are you panicking, people? By February 26th, Brazil has a case. Why is that important? All continents now have it, right? By March 11th, WHO declares a pandemic. Europe is the epicenter throughout March. We start avoiding gatherings in the United States. By March 17th, all 50 states have cases, right? We've gone from no cases to 200,000 cases, right? 12 days. So it took from January to March to have 100,000 cases. The next 100,000 was 12 days. The next 100,000 worldwide was 3 days. The next 100,000 was 2 days. The Olympics are now postponed. By March 26th, we are now in the United States, the epicenter. And the reality is that continues throughout most of summer. April, Wuhan opens up after a 76-day lockdown, right? The White House issues guidances for reopening in April. We have 100,000 deaths in the US by the end of May. We ban European Union bans travelers from the US, right? We now talk about emerging evidence in July of airborne spread. By July, we have more cases in Florida, right? The most cases seen, and no deaths in New York. We see the transition of our hot zones taking place here. And then the final aspect of this, right? Phase 3 trials begin, right? Russia approves a vaccine called the Sputnik V. We talk about the economic ramifications, right? Cost to global economy, $375 billion per month. By August, where Europe had been looking mighty fine, we're now see increases back in Europe. We see a case of reinfection in Hong Kong. We see cases in India expanded. By September, COVID cases in Europe are almost back to March levels. In October, we see the surge taking place here. And as of today, globally, we have 52 plus million cases, 1.3 million deaths worldwide. In the United States, over 10 million cases, and approaching 250,000 people have died. One thing I want to share with you, if you've not seen this site, it's by our friends at Johns Hopkins. It's the Corona Resource Center. Just do a quick search under COVID and Johns Hopkins, and you can get all the information you want, pretty much real time, kept up to date. And what are we seeing here, right? What we're seeing is an extension of number of confirmed cases worldwide. We see in the United States, we had a blip, that's the green line in March and April. We plateaued at a higher level than Europe, the red line, and then we had another surge, and now Europe looked mighty fine through April, June, and August, and now is surging above even the US levels. These are the countries most affected as of yesterday. The US, in terms of confirmed cases per million people, we now throw a denominator in here: UK, Germany, Canada, the world, India, and Japan. So we know we're now into what some people are describing as a third wave. It really has spread quickly. Here's a comparison of the number of days it took to reach the various millions: 1 to 1, 1 million to 5, 5 to 10. Notice that we're on this pace, right? We went from the United States from 5 million to 10 million in 92 days. In the world, from 5 million to 10 million, 38 days. So we know this is spreading. And we know we have multiple disease issues, right? The issue of diagnostics, the role of serological tests, the disease complications, the issue of personal protective equipment, how we turn into a mask-wearing society, the idea of transmission, large droplets versus aerosols, airborne, right? The switch over on that. The public health response, testing, tracing, isolation, quarantine, the role of social and physical distancing. But also, I brought up many other issues: health disparities in our community, the issue of health equity, how it ties into social unrest, the concepts of herd immunity. Do we all just get it and protect the planet that way? Well, very controversial, and the answer is no, because so many people would die. Our medical care response, right? Are we able to surge shortages? Do we have enough ICU beds and ventilators? All that's coming up as we're surging here again. The messaging, oh my goodness, how broken was that? Who's the messenger on COVID-19 from a national level, right? It's hard to say. Was it the president? Was it Fauci? Was it others? How was it handled at the state level? The issue of health communication, health literacy, disinformation, consumer product shortages, the economic impact, unemployment, the stock market fluctuations, events and travel being very much hurt by this. Its role in national leadership and politics. We just went through a major presidential election. How was that affected? And certainly on the international front, it's the international politics and the World Health Organization. We've made some incredible changes, right? Major clinical trial going on worldwide, coordinated by World Health Organization, 30 nations. So there's a lot of testing going on out there. What do we know? Remdesivir, right? An antiviral approved for severe cases. Different approaches. We're getting better at treatment. We don't have the miracle drug, but the use of steroids, dexamethasone. The decision, do you put people on ventilators or keep them on 100% oxygen? That's been game changers. The issue of patient positioning on their back or on their bellies. These are all changes going on. Hydroxychloroquine and that whole work. The use of convalescent plasma, the use of monoclonal antibodies, right? Emergency use authorization for a brand new drug just a few days ago. Vaccines, over 150 vaccine candidates in the pipeline, some in animal studies, some on the phase 1, the phase 2, the phase 3, more people in clinical trials. We're at the point right now where worldwide there's 6 vaccines approved for early or limited use, none fully approved. So we're making headway. And I'm going to complete this with another quote, right? Michael O. Levitt, who was Secretary of Health and Human Services back in 2007, talked about the concept without mentioning the One Health approach. But this is all filled with One Health. Everything we do before a pandemic will seem alarmist. Everything we do after a pandemic will seem inadequate. This is the dilemma we face, but it shouldn't stop us from doing what we can do to prepare. We need to reach out to everyone with words that inform, but not inflame. We need to encourage everyone to prepare, but not panic. And then finally, from sort of our newfound hero, Tony Fauci, Now we have something that turned out to be my worst nightmare. In the period of 4 months, it has devastated the world. And then the path forward. I remain an optimist. And part of the optimism stems from the concept of One Health. How do we look at the planet and the environmental health, its association with animal health, its association with human health? And we realize that the pathway is not going to be easy because we've never done it before. This is uncharted waters. A reminiscence, right? I mentioned that I had commanded this Monrovia medical unit. And here's my metaphor story. I've used this several times. It's been a while since I've used it, but I think it plays a key role as we complete this incredible series on One Health. It's oftentimes, much like our unit was surrounded by an 8-foot tall chain link fence, topped off in barbed wire, covered in tarpaulin. And when we were within our unit, it was there for a reason. It was there to protect our patients, their privacy, right? To make sure that our staff felt secure. But it was claustrophobic. And your vision as you were working was strictly at this. You couldn't see very far. One night, as I was visiting with my officers who were the heroes of the whole operation in Liberia, at midnight, the night shift always flipped pancakes, flapjacks. That was their meeting. I went for a flapjack get-together, told them how much I appreciated their work, I was proud of them, and then I'm heading back to my tent. And on the way to my tent, I run into 4 officers who are building something. I say to them, "What are you building?" They say, "We can't tell you." Not a good thing you tell a 2-star admiral. But I said, "Fine, just don't hurt yourselves." They had power tools, they had lights. The next morning, they wake, as I'm heading to the showers, I run into them. They say, "We did it, it worked." And they show me this. And it was a 2-person lifeguard chair. And I say, "What's this for?" And they said, "Just walk to the top of it." Right? I'm no dummy. I sent my aide, aide de camp, a young lieutenant, up first to make sure it was sturdy construction, and then I followed. And we got to the top, and we both sat there and smiled. And why did we do that? Well, we smiled because we can see, right? It was specifically built so someone could sit there and say, "I can see the outside world." But from a metaphor perspective, we can see our mission, right? We can see Africa. We can see the nearby village, right, that we were serving. And to a large extent, the metaphor of this is the lifeguard chair. And meetings like this, meetings on One Health, is the lifeguard chair. It allows us all not to be encumbered with just COVID and being blocked out, not just being encumbered with the difficulty of us achieving successes in One Health. But a meeting like this is the veritable lifeguard chart. It allows us to lift up and have that vision with this agriculture and natural resource world, working with the public health world, working with the engineering world, working with even our campus community to achieve a One Health goal. This meeting has done incredible things for us to focus on this. And ultimately, what's our goal? Our goal is, as a collective group, right, we have 111 people on board this now, completing this week of activity, is we're playing a role in completing this list. In 2099, the CDC will come up with a list. How much of this will be achievements related to One Health? It all depends on us. Thank you so much for your time today, and thank you for your attention.
Boris, I got to tell you, that was incredible. The amount of information that you provided and the intersection that you provided in terms of the environment, in terms of health, in terms of even breaking down some of the myths that we've heard with regards to some of the pandemics in the past and where we currently are today is huge. And you're absolutely right. These issues are so complex that they are not the territory of any particular discipline. It really requires multiple disciplines in order to be able to address this. Graham Binder, our Director for Communication, is going to be asking you a variety of questions that have come up through the chat section. But before he does, I'm going to start off with my own question. And that is looking at the dates, and I've often wondered this myself. You showed that on February 26th, all the continents had at least been infected to varying degrees with COVID-19. It wasn't until March 11th that the WHO declared it a pandemic. Why did it take so long to declare it a pandemic? And why is it important to call something a pandemic? What are the consequences of that?
You know, it's very interesting is when does a pandemic become a pandemic? And there's no real strict criteria other than, it's almost the World Health Organization is, you see it when you see it, you know about it when you know about it. The whole idea of that, technically they say when it's expanded, when it's in epidemic proportions in at least 2 regions of the World Health Organization in the world, right? Um, the pandemic with 2009 was called much more quickly. First case in April, pandemic by June. Here, when you look at a 2-month time frame, well, the reality is it kind of happened 2 to 3 months in the midst of all this. And again, there is politics involved in all this, right? You look at the idea of Ebola. Ebola took forever to be designated by the World Health Organization as a public health emergency of international concern. Why? Right? Even though it was brewing out there, right? I mean, CNN was already covering what Médecins Sans Frontières was doing and they were all screaming, saying, this is getting out of hand. The press was, in fact, a big primer of knowledge about Ebola. But the reality is there are ramifications of this, right? And the public health emergency of international concern for West Africa, the concern was, how is this going to affect the trade? How is it going to affect the economy when you basically say is, oh my God, there's a tainted area there. A pandemic means everybody's tainted, right? And in essence, it has its societal repercussions. And I think, we're always critics in public health of the World Health Organization, and it's a slow-moving organization, right? Part of it is it's, kind of United Nations based. It includes representatives from the whole world, some of whom basically, are out there saying, well, don't do it until you're definitely sure. There's no real good answer to that, Craig. But oftentimes it's, there have been lots of pressure, if you recall, of saying, well, I can't believe the WHO met. They have all this information and it's still not a pandemic, right? No strict criteria.
Boris, thank you. Graham?
Yes, sir. Thank you, Boris. Love the presentation. We have a number of questions. I just want to make sure that we're okay on time for you. I know
I am fine. I'm good
fine.
here.
Okay, so I'll get through these. I'm going to start with one from one of our own educators within the college. She's curious if the symptoms of COVID-19 were similar to Ebola. Do you think that COVID-19 transmission would have been much slower if not ended by now?
Yeah, it's interesting. When you look at, for example, MERS, right, and SARS, the reality is that when a virus is a killer, right, when it sort of presents itself, SARS and MERS had very similar type of symptoms as COVID initially, but it killed a whole lot more people percentage-wise, right? Right now with COVID, accrued rate is roughly 3%, and it's been going down. With Ebola, when you were off the bat, was in general, it was an 80 to 90% killer with previous outbreaks, right? A virus isn't do very well in terms of transmission if it's killing most of the people, right? And Ebola in particular was a terrible way to die, right? It really was. It's a hemorrhagic fever. There's bleeding. There's lots of fluid loss, right? And so the reality is that people with Ebola, when they got sick, they stood out, right? The idea was that, yes, we were measuring fevers in Liberia as an initial incident, right? And so people with fevers were being tested. Once you were tested with or without symptoms, we knew how bad it can get. COVID-19 really is, it's the worst, it's kind of like the worst nightmare for us all, right? The number of asymptomatic people, oh my God, if you had designed a virus to say that 40% potentially will be asymptomatic spreaders, that keeps the virus going, right? So yeah, totally different picture.
Second question, bear with me, there's a couple moving parts to it, but
Yeah.
I'll streamline it as best I can. So it seems that one of our greatest challenges from this person's perspective, one of our greatest current challenges to public health, particularly as it pertains to the COVID-19 pandemic, is some of the deterioration of trust in institutions. This is driven by political divides, sort of the fragmentation of the media, proliferation of different media outlets, and also some missteps made by federal agencies early on. And to be frank, they continue to happen. How do you how do you see UMD and SPH and AGNR playing a role in restoring some of that faith beyond just sort of screaming from the rooftops, believe our scientists, believe science?
Right. Well, let's start with the federal agencies. I mean, I'm going to be nonpartisan here, but the reality is that we had lack of leadership at the highest levels of the nation, right? And that's a nonpartisan approach. That's true, right? Because unlike previous public health crises that we've seen, some of these infectious disease disasters that we lived through, where science, public health, medicine, yes, leaders in One Health were in fact the spokespersons, right? And CDC and FDA were given the ability to do their jobs without necessarily interference. I'm not naive enough to say that there's never political interference in these things, but political interference came to a whole lot different levels on this case. So those agencies are going to have to be able to regain our trust. They're going to have to. I mean, there's incredibly talented people, right? The career people within those agencies who believe in the mission. Leadership will have to turn over without a doubt. That's the way you begin the process of healing in that. Regarding us and sort of AGNR's and SPH's approach in Maryland community is, it's not just believe in science, is first of all, let's be humble in science, right? So the humility starts with this. Guess what, folks? We're only 11 and a half months into this, right? This is it's not even been a year, and look at the progress. Yes, we've had failures, but what science isn't filled with failures? Hypothesis generation, hypothesis testing, results, and then you move on from there. That's what we've been doing. We don't have all the right answers. So part of it is humility, which is mask or no mask. Well, initially everybody said no mask. The prime reason for that was what? We're not a mask-filled society in general in America. And secondly was this fear that if everybody did a run on the bank with masks, there would be none left over for the first responders, for the healthcare providers. That was the impetus. And then at some point somebody said oh my God, we got to do something because we ain't got an antiviral. We don't have a vaccine coming up quickly. 2009 was baby steps compared to this because every year we put out an influenza vaccine. It was almost like that we can get a brand new vaccine out with a brand new virus. Not going to happen with COVID-19. So the reality is one, humility. The secondly aspect is let's go back to the data. Let's make decision making. And that this starts at the university level. Every decision that we make at the university level should be based on data. Now, decision makers don't always rely on scientists, even at the university. I'll be honest to say, Craig was kind enough to say that, School of Public Health, we're playing a role in the COVID response. Yes, we're there. But does everything the dean of the School of Public Health say is taken by leadership? The answer to that is no. That's the essence of leadership. So I think it's the whole idea of rebuilding, right, and healing.
Sort of along the same lines, Boris, what as you commented there on our role and our responsibility in education and restoring some of that faith and kind of bringing folks along and giving them some tactics and strategies to deal with the virus. What do you think some of the keys are to successful long-term control of COVID? Because this, as you mentioned, this is different. Vaccines may not come for a while, and if it does come, is it going to reach a broad population? So is this something that can be eradicated, or are we going to have to live with this type of new normal for a long time?
So first of all, when are we going to turn the corner? And turning the corner is, so I'm even telling my students, right? Next semester is going to be a lot like last semester. Next summer is not going to be like last summer. So I think we're at an important point like that. So that's my optimism. Is going to be back to completely whatever was the previous normal? The answer is no, but it's going to be different. Game changers. One, and I saw another question that we had on there talked about the mortality. First of all, in the 11 and a half months, we've learned certain things. Treatment-wise, right? Lower percentage of people are dying because we're getting better. We have more knowledge in the 11 and a half months of, I'll use that term, the practice of medicine. It's practice at times, right? What worked, what didn't, what saved the life, what didn't. You begin looking at trends, you start changing your practices, and you save lives, even without that magic medicine. So that's one component. We're going to get better at this. We have to get better, and there's already been an explosive sort of advancement. We have to get better on the diagnostics front, right? What we need, and this will happen with time, is something that I can just do at home right? Swab my nose, spit into a tube, do something that tells me, do I have the disease or not? And has a good enough sensitivity and specificity for me to believe in it, right? Whether it's at home, whether it's point of care, but we got to get better at diagnostics, and we have to make sure that that's out there so that if I'm infected, I know what I'm doing versus just going out into the world blindly. Because guess right now, even at the university, God, we're being tested every 30 days. Everybody knows I could have been negative 30 days ago and I could be positive, and so we got to get better at all this, right? The vaccine, initial information, as we know, is based on the Pfizer BioNTech vaccine, is it looks mighty good. It surprised everybody how good it is. Is that going to remain? Well, we hope so. Is it going to be available to everybody? Look at the proposed list of the numbers of doses that are going to come out from them, plus all the other candidates. One, we will have multiple candidates. That's a good thing. Second thing is, I'm a healthy 61-year-old. Guess where I stand right now on the list of priorities to get the vaccine? I'm pretty much at the back of the list, right? No real big chronic medical conditions, not old enough, not young enough, not sick enough, right? So the reality is that we can't rely on the vaccine being the savior for us, right? We're going to have to learn to live with this. Are masks going to be part of our intermediate future? Probably. And then ultimately, what's going to happen with the virus? It's not SARS that disappears. We know it. Is it going to become part of an annual aspect like influenza? Oh, it's COVID season again, right? It could very well be. I don't even can answer. None of us can answer the question, how good is this vaccine going to be in terms of how long is the immunity, right? Is this now another annual vaccine for the general population like the flu vaccine? Too many unknowns, but we're going to have to learn how to live with this.
I'm going to ask just a couple more because I think we internally we need to pivot to our
Absolutely
poster session. And Boris, we want to be sensitive of your time as well. We have a number of excellent questions, so I'm going to narrow it down to these last two. Why do you think that China's COVID case number has remained so low when we have seen such a big resurgence across Europe and also in the United States?
Yeah, I mean, it's a great question, right? So other than the fact that China really took this rather aggressively from the beginning. I mean, look at the model at Wuhan, right? The rest of the world kind of said is, what the heck is going on in China? Only in China can you shut down the whole city, right? You put up blockades in essence, right? And you tell you can't leave, and you can't come in. And the rest of us, let's remember how we felt about this. Oh my God, that's human rights. Oh my God, how can they possibly do that? Only in China can you do that. Well, guess what? Part of the lessons learned is that formula was effective. In 76 days, Wuhan has reopened. But it's not just a matter of shutting yourself off. It's what do you do while you're shut down? And here's sort of the formula of success that we've seen in multiple countries, not just in China. You get aggressive on the testing. You get aggressive on the quarantine and isolation. You let people know what they need to be doing. You support them through this whole issue, right? And you begin getting a hold of all this, right? So the reality is that it's not just a shutting down, it's the public health response. How aggressive are we at doing what we do? And how good is the general public in taking the public health recommendations and following them, right? How is it that our crazy world here in the United States, basically, as we all know, turned masks into a political statement? Oh my God, it's a public health thing. It's a public health thing. It's not, but no, right? We got so destroyed over the idea is, are you a believer or a non-believer? And the believers wore the mask. I'm being, kind of, bold in the statement, but that's how broken it was. And so we have to fix this because we know models. Look at Australia, look at New Zealand, look at Taiwan. Yes, some of them are islands, but look at other success stories. South Korea, a lot of testing going on. China, testing, telling people what to do, right? So it's doable, but we're really behind the eight ball here.
Thank you. Finally, and this is a question that's I think near and dear to a lot of our hearts, including myself, who have I have a young daughter. What is your interpretation on the available data as it relates to the role of schools in children in COVID transmission? And this question is asked in the context of the tremendous tolls that the social, the mental tolls that this is taking on the children and the parents for kids not attending schools. Like, how do you balance that?
Yeah, it's a tough one because the data, again, if we want to be data driven, what we've seen for the most part is that schools are relatively low centers of activities in terms of spread, right? So we've seen the model in Europe where many schools opened up quite early. And in reality, in that model, even though other places, right, the bars, restaurants, et cetera, are being shut down, the schools remain open for the most part, unless things turn out to be really, really bad. So on the school front, the jury is out, right? The data is still out there in terms of what the best approach is. The problem, of course, is the issue of not just spread among students, but what happens, right? And this is where science has an issue, right? Which is spread from the school to the household. Are people in the household getting this? We're not very good at the idea of contact tracing and the idea of exposure to staff at the school as well as teachers at the school. So you have potential higher risk individuals. So I don't have an answer to what the right approach with schools is. In reality, we go back to the basics of public health. When I know a disease ultimately is flourishing yet again, right? And we know we're into, well, again, whether you call it a third wave or a continuation of our first or second waves, we know we're getting worse in terms of both number of cases and now recently hospitalizations and deaths. The key feature is you try to keep people away from each other. And the question is, how deep do you go? Right. And we're all taking baby steps right now. The reality is that, people are, and Mike Osterholm yesterday was crucified over the term as we're heading potentially, or one of the, I didn't really say that, the lockdown, the shutdown scenario. The reality is if I have a disease transmitted from person to person, I got to figure out how to decrease the contact persons to person. And how deep do I go? It all depends on the epidemiology. If I can turn the corner by closing down some businesses where people congregate, limiting the number of people getting together, good enough. But if it's not good enough, I have to go deeper, and perhaps the deepness of this goes to the school level.
Well, I think we'll conclude the Q&A portion there. Boris, thank you so much. This was a pleasure to be involved and have the opportunity to spend an hour with you. I think we all learned a tremendous amounts. Wonderful questions. I'm sorry to those questions that I did not get to ask, but we are
great. Well, it was my pleasure. Thank you to Dean Beiruti for the invite. Thank you to all of you for putting together this great program. And we look forward at the School of Public Health with further interactions with your faculty, staff, and students on this One Health mission ahead of us. So thank you so much.
perfect.